We had a conversation before this last week, and we just touched the surface after an hour. So we expect a lively discussion today. And the first thing I always like to do is say, what's your background, but what in your life got you here today at this place that we should know about and understand? And I think that understanding is very important when we're thinking about work in the community and work in health equity. So we're going to start there, and I'm going to ask Henry to kind of walk us through his background and what I think will be an interesting discussion about his specialty. So Henry, could you give us your background and your origin study and where you are today?
Sure. Thank you, Daniel. So I am a Vietnamese refugee. I was born in Vietnam and have a lot of memories about the war and the bombs and the takeover of my country. I left Vietnam when I was 5 and came to the United States, sponsored by a church, and relocated in Stockton, California, which is a small town. Back then, it was a small town in the 1970s. How I got to becoming a doctor, I think, was fairly convoluted, but it centered around a theme of really being afraid and having really challenges with access to communication and to healthcare. We were one of the families that in the early years of being refugees, my parents were called on with CPS because of a traditional practice that we had of coining, and that kind of looks like whipping, but it's actually a way in which Vietnamese and many other cultures, we sort of release bad humors. But back then people didn't know about that, and so we had some conflict, some confusion with the healthcare system, and that really prompted me to learn more about health, because oftentimes when we had health problems within the family, either there was money issues or cultural issues that prevented us from accessing physicians and nurses. And so the parents would ask the children, we would go to the library and try to find information about what was ailing us, and that put the seed of interest in health that eventually led me to become a doctor. And the specialty, so I'm a psychiatrist, and the specialty within psychiatry that I focus on is called cultural psychiatry. And cultural psychiatry is really the study of how culture helps us to understand how we are ill and how we get better. And it really posits this idea that most illnesses have a very strong social component to it. Things that we now, I think, acknowledge in broadly in medicine. But back then, cultural psychiatry was very focused on, helping physicians and health systems to understand that, it's not all biological, that there are some real strong social and cultural components that are blinders for healthcare systems in terms of engaging and understanding the healing processes and the illness experience of people who don't connect readily with the health system. And so that became part of my practice. If you will, it's sort of me sorting out the experiences of health care in my childhood and sort of bringing that to a professional level and extending that to other communities.
You had a lesson in cultural sensitivity at a young age. Reshma, what is your story?
No, I just want to thank you for having us here today. Always good to see you, Daniel. My story, so I'm a first generation immigrant, parents both from India, but actually grew up in the Midwest, grew up in Wisconsin. And so I think there's lots of factors that kind of brought me here, but I think one of the biggest factors and influences has been my mother, both my parents, but I'll say my mother today. One thing that I think was so valuable is she was actually a social worker who worked in India, in the slums of India, working on leprosy and TB and stigma. And in her generation, she's just about 70 years old now. women working in social work is not that common. And immigrating here and then immigrating into a state which was, I'll just mention my high school, I was one of 8 people out of 1,600 that was non-white. And coming into that, kind of environment and focusing on social work and immigrant health or immigrant issues was really shaping. A lot of her work focused on this issue of acculturation and assimilation and how to maintain a culture within kind of our country and not losing some of that. And so from a really early age, I was exposed to a lot of the work that she did and actually took part in a lot of it, from trick or treating to, other kind of events. But a lot of what we did was focuses on this issue that comes up with language barriers. So the elderly in communities, especially in the Hmong community, they were brought in also as refugees, helping the US during the Vietnam War. Almost like 150,000 were brought as farmers to the Midwest. And the elderly that were there didn't have the language, but traditionally, are the elders that are respected in the community and help make decisions. But the children were in school and the children were learning the language. And so when emergencies happen or there's interactions with police or with healthcare, they often had to take the lead. And this role reversal was created in the community. And so being able to see that and experience that, I think seeing how healthcare or even law enforcement would engage with, similar to Hendry, kind of traditions of the country. So marriage and the age of marriage and how marriage and engagement happens is very different than traditionally in the US and kind of how that was taken. I saw a lot of that firsthand. And so when I was interested in community health or medicine even, I bring those visions, that experience, my mother's experience, those families, those faces are, ingrained in my memory. I'll mention even, I came out to the West Coast, trained at Berkeley and in San Francisco, but during COVID, during the shutdown, my mother had a stroke, and she actually had a stroke at home because of a lot of the concerns around COVID at that time. And she has a language accent. She's a professor actually, but she was, there's a lot of concerns about how she was treated, I think, just due to her accent in advocating for her care. And so I think it still rings true today and really shapes the way that I approach wanting to do community health, to bring those stories to life, because they're real and they're still happening even this late in my career.
Thank you. But I think both of your stories really shaped who you are today and the work you do and the skill and the passion that you bring to community-based health equity. A lot of people are doing community-based health equity. Why is your system better than other systems, or what are you doing right? What does it look like to do community-based health equity at UC Davis? Henry?
Well, I think that's there's a lot that we need to do better. So I think we as a healthcare system, we as a group of healthcare systems, there's a lot of opportunities, and we're on that journey. I think the first step in this is to really look at definitions. We talk a lot about community trust and how it's so important for us to build community trust within various diverse and underrepresented communities. But I think that that sort of misplaces or distracts from the opportunity of growth that we as healthcare providers and healthcare systems have. And so we're using really the concept of trustworthiness. Now, let me just explain some significant differences. So community trust connotes what a community member might feel towards their health system or provider, and some of the mistrust that our community members have, our patients have, is well-founded. So there's been a lot of I think talk recently about historical racism, and the AMA published some statements about that, AAMC as well, recognizing that there is this history of abuses and missteps that we in medicine have made over the decades and centuries that we've been in existence. You know, the Tuskegee experiment, the unlawful and immoral experimentation of enslaved women for the sake of understanding better obstetrics. These are examples of the mistreatment that medicine has done upon underrepresented communities. And so there's sort of an adaptive quality to not trusting the system. And we know that there is a lot of, there's significant health disparities that Black and Brown communities have. And so a well-informed person coming into a healthcare system from Black and Brown communities probably ought to have a healthy degree of mistrust, given the evidence that we have accumulated, suggesting that people from Black and Brown communities don't fare as well. And so to try to increase trust in a community where mistrust is well-founded is actually unrealistic, but also borders on a little bit of being inhumane, right? To try to convince someone that they ought to have more trust, that something is wrong, that they are not trusting we doctors enough. So shifting to trustworthiness really focuses on us, that yes, we have this history of mistreating populations, and that we need to do something better to earn the trust, to be more trustworthy, so that the focus of intervention, if you will, is not on trying to increase the trust of someone whose mistrust is well-founded, but rather to increase the trustworthiness of us, of systems that have a history of being untrustworthy. And that is sort of the first step in, I think, our approach towards improving our relationships with our patients and our community members, is to recognize that their mistrust is well-founded. It's founded in history, and it's founded in current evidence, and that points to our need to improve our trustworthiness.
So Reshma, that's very helpful, Henry, and David Williams from Harvard talks about that distrust is a protective shield against historical events that are throughout and microaggressions that occur on a daily basis. But what did Reshma, what did UC Davis have to acknowledge in its history before proceeding with community engagement?
Yeah, I think the story here is not so different than a lot of other places in the country, but we do sit as a large academic center here now, but historically, and I know Hendry and I have talked about this quite a bit, historically UC Davis history is unique in that it was initially built to be an institution serving the community. The area in which we live in California has been traditionally more of an agricultural base within the state. And so being able to, provide for that community has been part of that history. But I think as the city develops, the institution has actually been initiated based on land grants, right? And being able to kind of provide that back in kind of with responsibility to the community. But I think as things change, as the city changes, as we became more of an academic center and kind of changed the way that we mold, like many centers, from individual interactions to kind of, decisions based on policy of insurance coverage that we cover and changing leadership. All of those come into play of having issues with trust, that are similar to a lot of places, I think, in the country. One issue, I think that even in the last decade that has happened is this issue around underrepresented communities and insurance coverage. And we've taken bold moves, especially in the last few years, in expanding that. But that history of even community-based organizations that are, had worked and had this kind of traditional relationship with our institution changed, right? As insurance coverage changes, and being able to bring that back, build those relationships back, is a growing process, as Hendry mentioned. There's a lot of efforts, I think, that have been done even beyond that in terms of connecting and really learning. I think being in a standpoint where we're learning from community leaders more than meeting in a way that's more top down. I think that's a huge approach that the institution's taken. And one of the things that I think I've really worked on, and especially in the last few years, is building capacity. So for our leadership that are maybe even new to this field, being able to have a venue where they can talk about approaches of this in a more of a coaching perspective, bringing groups of people both that are working, in from a medical perspective, both within our clinics and our hospital, as well as our FQHC, or kind of our clinics that aren't owned by us, but feed a lot of patients through our emergency room in our hospital, where we have relationships with that may have different resources in terms of, how they operate, to come together and actually coach each other on what might work, how to word things when things go wrong, and to have an open environment to share when they go wrong and to get advice from each other. Hendry, I think you have some great stories about some of the initiatives straight in the community with the healing circles too. That might be a good example of how, bringing in community voices to deal directly with trust in itself. UC Davis is kind of taking a step in that direction.
Yeah, and Reshma, I think that to what you're saying, I think that in order to really improve our community relationships, to earn that trustworthiness, in addition to working on what we do well, which is healthcare, I think we have to also acknowledge that we are more than just healthcare. We're neighbors. We're neighbors in our community. We live together. As an institution, UC Davis has grown very, very rapidly. And, we've contributed to gentrification in our local community. So we weren't living well with our neighbors. We were bringing in new people and displacing our neighbors. And so part of this, and this is something that Reshma and I have worked a lot on, is thinking about how do we address poverty? How do we address jobs? How do we address education? How do we address the living situation of our local communities as well? And so we have an initiative called our Anchor Institution Mission for Community Health Initiative, or AIM for Community Health. And that is really looking at us, redefining again, not just who we are as a health system, but who we are as a neighbor, that we're an employer, that we do business and we can elevate local and small and diverse businesses, that our footprint impacts the lives of people around us, and that we have to be mindful and sort of leverage that influence. So part of our projects, we're building this grand hospital tower. And one of the things that we've required for anybody that is working with us as a subcontractor, they have to make sure that they have a plan to hire in the local community and engage with local businesses as well. So that's one of the ways that we are trying to address not just health from a focused, healthcare standpoint, health services standpoint, but health from the standpoint of being neighbors, being in fellowship with our neighbors and communities.
Yeah. I was very impressed by your consultation with people who are working in this area. And could you talk a little about that? I think it's kind of a unique thing that you really have a consultative practice around health equity. And could you talk about that some more? I know you have a anti-racism and cultural humility fellowship, and there's consultation there, I'm sure, but there's consultation for anybody working in this arena on poverty, food security. So could you describe that a little bit, Reshma?
Yeah, no, I think this is this came out of stemming from a need to grow. I mean, we're in a hat here in population health where we are working in the community, thinking about quality, thinking about value. And to do that work, we want to bring in patients to develop them together. And in doing that, we needed help. You know, I myself, and I think this is a story of a lot of people, I didn't necessarily grow up in where I'm working. And the story, I know how important that is from even, you know, our introductions here today about the communities. And so I went knocking on Hendry's door and I said, Hendry, I need to better understand what are the issues around trust? What are the issues with different communities? And with the data that we have, I think a lot of the language we speak right now, and everyone's racing to this, is take our data and stratify it by race, ethnicity, age, and all these things. And we did, and we found, what was it, 52 areas of potential opportunity is what I call it. But we found and uncovered a lot of these potential areas of improvement. But to do that, we needed help because we wanted to be able to approach the community in a way where we were really understanding their issues. And so, you know, it is cliche. I think there's a lot of folks that use community health needs assessments. If you have that resource, it's a pretty intensive resource to develop that. But there's so much more to how to use that. And what we realized is that what we were thinking about in a very medicalized way, it's a different language in the way that the community describes it. And I think I learned a lot of that with Hendry as well. It's like when we talk about heart disease or we talk about diabetes, you know, they're talking about nutrition and they're talking about obesity and other things that correlate and are kind of compiled together conceptually. And so we needed to bring people that were really interested in doing this work together to gain that coaching, gain that knowledge and understanding. So what we did is we started primarily, we were thinking about the doers, the operational teams spanning from different parts of our organization. And we brought in some of those community clinics as well that aren't formally even part of our institution, but there is that relationship. We're neighbors in some ways from a health medicalized kind of perspective. And we brought in our disparity experts, researchers, those that have grown up in the community, different types of communities within zip codes in our region. Hendry's guidance and some of his team with his center as well, and having that partnership be very, very tight. And what we have is folks that are working on different areas come and they share what they're doing and they get advice, and we ask them to, what specific concrete advice are you looking for? And we provide them an algorithm to say, to start this work, here's, you know, a 10-point algorithm about what is the area that you're working in. Is it a problem truly locally? You know, have we looked at the local data? What is the history of this? What communities is it affecting? What has the institution or other groups in the community done? How has that gone? Did that go well? Talk to the person in the institution, maybe that was involved or even outside, to gain that history. What leaders did they work with? Don't reinvent the wheel from scratch. And then bring in that question. And it's just been a really, really robust way to get discussion going. But I think this is kind of something I didn't realize. Our experiences and other clinics that aren't even in our institution, but that we've integrated in, are dealing with so many similar issues, but they also, being resourced in different ways, have different solutions that the other group hasn't necessarily thought of. So one might have the technology, but one has the relationship and they know more of that history. And so from a QI perspective to a community assessment to building these relationships and sharing failures, we called these patients in this outreach and it was not taken well. What did we do wrong? You know, and having these honest discussions have been so fruitful. I think that's, you know, Hendry, you can speak to this a little bit, but kind of the best feedback we've gotten from the group is just an honest place to be vulnerable.
Yeah, and I would say that the partnership between Reshma's office and my office, I think has worked really well. You know, my office comes in with that health inequities, DEI lens, and, you know, community lens. Reshma's group comes in from, you know, a population health standpoint and also from a clinical standpoint. And together we're, you know, I don't consider my office as the consultant and Reshma's office being the client. I consider that Reshma's office and my office are in partnership and we're the consultants. And the reason why is that the health inequities, the health equity researchers and the folks that I work with, we have really, you know, I think strong ideas and perspectives around health inequities. Reshma's group has really great ideas and insights around operationalizing clinical services to meet the needs of populations. And I think it's the combination of having the relevance for health inequity and the relevance for community and the relevance to the clinics that will need to, to make those changes or implement those initiatives. That I think is really important. Both ends feeling that the project or initiative has high relevance to them. And if it were just my office operating in isolation, or I think if it was just Reshma's office operating in isolation, we would have one end of the relevance, but not the other end. And together, I think we've I think done some really productive work because of that.
You've got the cultural elements, and then Reshma has a systems thinking cap on. So we had talked before, and I was really interested in this acknowledgement of past misdeeds, if you will, and talk a little bit about these healing circles that you've employed to really begin to think about the acknowledgement of previous racist, discriminatory practices and how that has healed the community.
Yeah, so one of the things, so we are the first academic health system to be designated as a Truth, Racial Healing and Transformation campus center. And so a lot of the work that we do is around, is around racial healing. And just to give some background, a lot of, I think a lot of communities have experienced racial trauma historically or in the current here and now. And it's really been a challenge for we in the health care professions to deal with that directly. We often see the sequelae of it, and we often try to deal with it from a very clinical standpoint, but we don't really have the I think the training to really go deep into the historical aspects of it and to sort of promote community healing. So racial healing circles is it's a format that was originally actually developed by indigenous communities, particularly in the Pacific Northwest, where you would have these community talking circles where people get together and talk about complex issues and share in their experience, but also going towards solution making. And so racial healing circles really focus on the traumas associated with racism, how to understand that. And so our providers and we have mixed circles that include community members as well as healthcare providers, staff members, educators, getting together to sort of talk about what has been the impact of this, a particular racial trauma on their lives, and to be able to be in a context where it's safe to be able to express and to hear that, and then to work towards a solution. So part of these racial healing circles is based on restorative justice circles, which really focus on this idea of acknowledging the harm, but also focusing on community rebuilding. This idea that in the end, the goal is for people who have been harmed, as well as people who've contributed to the harm, to be able to find a pathway back into community. So an example that I'll share is that, so part of our role is to build capacity both within our health system, but also within the communities, teaching community members how to conduct and hold healing circles as well. And so one of the consultations that we had was in a county that was trying to improve engagement with LGBTQ communities as well as underrepresented communities of color. And as we were going through our consultation exploratory process, we came to understand that the local LGBTQ community center, there was a lot of hurt with transgender people and LGBTQ communities of color, feeling that this LGBTQ community center really ignored that part of the community. And so there was a lot of fraction, a lot of pain associated with it. And so our role as a health system was really to recognize that there was trauma and there was an opportunity for healing. And so we conducted forums and healing circles to bring the community together and to help foster healing and cohesion within the LGBTQ community. The end result was that it took some time, but the community, the leaders of this LGBTQ community center started to recognize the impact that they had on transgender and communities of color, and started a campaign, an initiative to really incorporate transgender and racial inequity, health equity issues within their organization. We ended up significantly improving the engagement of LGBTQ community members in general, and specifically transgender and LGBTQ communities of color with healthcare services. Because of that community healing that enabled this community center to serve its purpose of connecting communities to social and health resources.
That's great. There's a great question in the chat that I wanted to ask. Catherine Heflin says, really enjoyed the angle of being trustworthy and validating mistrust in the healthcare system as a starting point, but she'd love to hear guidance for providers that are and advocates on how to balance this in the age of misinformation. Anybody want to take that? Reshma, you want to take that?
I can take part of that. And then I think also, Hendry, especially some of the work with COVID too, I think would be, I'm sure you have some things to share as well. No, I mean, this is kind of broad. The question is quite broad, and I think it's broad advice as well that I would provide on this. But I really think around this in the age of misinformation, this is about getting on the ground and connecting with people. I really feel like the ability to create that relationship is what brings us to that next level. Hendry, I think, might share some examples directly from Davis, but also I previously worked in LA County too, and a lot of that work that was done was getting out in the community and getting local advocates, community health workers, folks that are from the community, know which houses are where, know where folks are spending time, and being present aggressively, on some of these issues where there's harms coming to the community by either taking certain actions or not taking certain actions. So, I think this is my general advice is that there's no easy, quick fix for this. The hard work is needed to do this, and the investment to do that and get on the ground. And it's not needing to, and I'll kind of repeat this from before, it's not needing to replicate all, everything from scratch and build all new wheels. There is infrastructure. There are people out there, but the relationships are what create that. There's people out in the communities working in CBOs or just others out in the community in organizations or faith-based organizations that have these same goals. And with those relationships, your army, doubles, triples in size to be able to do that work. And so that alignment and that relationship building is key. COVID's an example. I think there's lots of examples around the country for that, but being able to really commit to that and commit staff and resources within our institutions, especially healthcare systems, to have those networks that are not casual, but sustained, and that have spent that time understanding their history. I think that's what gets you over that hump. But Hendry, you might have some very specific examples here as well.
Well, I think just to build upon what you said, Reshma, I think that so I think about it from a system standpoint, and then I think about it from an individual standpoint. Like, what if, as a healthcare administrator, how do you address this? And then as a provider, how do you address it? So from a system standpoint, yeah, I think as Reshma said, there are a lot of trusted community-based organizations, community clinics. I think we found out in the COVID area that community clinics were a really important source of trust when it came to healthcare. And so really making sure that we engage and cultivate partnerships with CBOs, FQHCs, and other community health and service centers. And that is to say that let's start now. Let's not wait till the next crisis, but let's start now so that we develop an authentic long-term relationship. Oftentimes, I used to work in a CBO, a community mental health clinic, and I would say that our margins were very thin. Like we talked about closing every year because our funders didn't pay us on time, and so we couldn't pay our people on time. It's sort of an irony that that a lot of these community-based organizations, we ask them to sort of really be on the cutting edge of some really innovative ways to engage in communities, and they take the risk of failure, and yet it's hard for them to absorb failure. Whereas we as highly resourced healthcare institutions, if we fail, we have a lot of resources to recover from that. And so, really just pointing out that long-term relationships, I think cultivating support in the long term for these CBOs and community clinics, I think is really important. Now, from an individual standpoint, and this is bringing in the cultural psychiatry lens, is to really ask yourself the question, what if I'm misinformed? What if my patient's experience and perspective is real? Because it is real to them, and they're the most important maker of reality for their life. Not we doctors. We have like half an hour, 15 minutes, maybe an hour with them, and then they live their life, and whatever information that they get gets reinforced in their life. And so the first step is to entertain this idea that what if actually their perspective is just as valid as mine? And when you take that stance, then curiosity comes in, and that I think is really important, because the more curious you are about your patient's perspective, even if it's not a biomedical perspective, even if it's a spiritual perspective or a karmic perspective or a social perspective, if you're curious about that and you ask those questions, what will happen is it'll evoke this social psychological phenomenon of reciprocity. And what will happen is that when you say, can I share with you my perspective based on my experience, they'll be much more inclined to listen to us, to hear us out as well. And so we build this foundation of a relationship upon which we can have disagreements and differing ideas, but they understand that that we are working in their best interest. And so that, so that I would say that that's a starting point for addressing misinformation in the individual level.
It's the physician trusting the patient, and I love this idea of curiosity. Curiosity is the link to empathy. You show empathy by being curious. So I just love that. A lot of institutions, when we talk to them about trust, they kind of scratch their heads. And you seem to have gotten to the trust issue quite quickly. What's behind that you're seeing something that other institutions are not framing it within a trust frame? Any thoughts on that? Why did you come to believe that trust was so essential?
I have some thoughts on this, but I mean, I think I don't know the answer completely. Part of it, I do think is as individuals, we have our own life story that brought us where we are, and I think a lot. Actually, the way that you framed some of this discussion brought that out, Daniel. But the issue of trust was not a hard sell for, I think, some of the leaders at our organization, but I can't emphasize the importance of leadership and choice in leadership for that. There is some magic going on here at our institution in the fact that I do think that there are some believers within, at least with me and Hendry, and I think some of the other leadership. But when you have that, where you don't have to spend all the time making the case that this is important. With all the energy, things do roll, but I also think the difference is, why is that? Why is that the case? And part of that is the mission, right? That even from what we were saying of how this medical center was developed and the community and the purpose of it and the mission back to the community to serve the community, it has deep roots. And so even if it's gone through gentrification and some of these changes like Hendry described, there are faculty here, there are students here, there are, other pieces of the organization that have been committed. Like neither of us are directly, running our medical school, but are associated with it. And it's always one of those, top 5 for most diverse student bodies in our medical school in the country. And so, it's not just this alone, but it's, there's different pieces to it that I think bring that about. I've worked in 12 different health systems and I've seen them, and it feels different. It feels different from that buy-in and that history perspective. And I would say a humbleness perspective in leadership. There's something in doing this work where a patient, a community member, a CBO leader can kind of tell you their truth, and it doesn't sound good or feel good to you, and you're still okay moving forward, knowing that that is the truth. That is a rare finding in leadership.
Yeah.
But I feel like it's a unique place. But Hendry, you might have
humility goes a long way in community work. That's for sure. That and curiosity. There's a really good question that I want to get to in the chat. But Henry, did you want to add something?
I just appreciated Reshma, your comments. My big health system has been UC Davis, and I've been here for quite some time. So it's really edifying, Reshma, to hear your comments about that. Having worked in multiple other places, I would say that, as Reshma pointed out earlier, we were created for the community. And I think we've really made sure that people remember that. That's been an important part of our strategic plan and finding our identity. I think the other factor is that it was a big wake-up call with COVID-19, right? That's this idea of build it and they will come didn't happen. We got the vaccines, and still, a significant number of people don't trust the vaccine. And so I think recently it's been a wake-up call that we don't have the trust that we thought we have with many communities.
Getting back to Reshma's comment, I think looking at the entire ecosystem of the entire university and within that the medical school and the origins, I think is really important and probably helps you a lot in thinking about things in a broader lens than just the health system. Reshma, I'm sorry.
Yeah, I was going to just add to that point, actually, but with a different example. It is that ecosystem. I was looking at one of the previous additional comments by Catherine about the worsening of health disparities. We have spent a lot of time thinking about this in terms of data, right? Where we have visibility, we can take action from an operational perspective too. And where we're blind, we don't know where to go. And so our ability to really be honest about the data that we have, the limitations of that. So in population health, that means the definitions we're using for race, ethnicity. It means the risk model and the populations that are left out if we don't have good data because people are not as trusting with us. Are they going to come to get all the labs? Is that data even there to have knowledge about, who's high risk for XYZ? And then are we negating services to them because they're not pinging as someone that may be high risk? And we've spent a lot of time kind of navigating this, but what it takes to navigate it operationally is we need a Hendry, we need our equity experts. We need the folks on the operations side where I sit in, but we need our data team, right? You need that 3 or 4 part system to not live in a silo. And I think that's the other part of the culture is de-siloing. You can't do this work alone, to Hendry's point and to your point as well.
So that interdisciplinary team and different skill sets coming together, I think, is really key to your success. There's a great comment from Janice Tufty, our regular viewer, and she wants to know, you've talked about restorative justice among the community, but how about within the physician clinician community? any safe spaces where they can share their trauma and perspectives too. This is often referred to as peer support, and there's a lot of peer support in the country going on. Joe Shapiro was very involved in it previously from Brigham and Women. Have you had any experience with creating safe space for physicians to talk about their trauma?
Well, I think that that's really important. Physicians, we experience we carry our trauma into medicine. We experience vicarious or secondary trauma. We're put in really challenging moral dilemmas that also are traumatizing as well. So all to say that this is a really important and great question. Burnout is a big issue amongst healthcare providers for these reasons as well. I would say that I've had experience with Rachel Remen's finding meaning in medicine and her work around healing arts as well. We do that for our medical students, but as part of the training, we engage our faculty in on that, and then they have finding meaning in medicine groups independent of the students. So that's, I think, one way. I think it's a big opportunity to really engage our wellness efforts, but I think that there's a logistical challenge that we have to commit to, and that is giving our physicians time for this. And I've heard of the saying, wellness by 1,000 paper cuts, I think is the saying, where like there's been this push in wellness, but not a commensurate allocation of time to engage in wellness activities. Yeah. And so the wellness itself becomes this sort of obsessive, unreachable target, which actually worsens wellness. And so I think it's really important that institutions commit the time to it, not just the programming and the messaging around that, but actually to commit the time to that, and that is challenging.
And I wanted to add one thing to what Hendry was saying, and this is just a huge thank you to him and in his group as well. But one of the things I think as an add-on to that is, what about those disparity experts? What about the folks that are getting tapped all the time by my team specifically, probably, to do this work and to get that guidance? And so there's also a foresight. So when we're talking about compensation, Hendry's actually built a team of multiple physicians that actually get funded and paid to do these consultant roles on specific, more in-depth projects. And so they're tapped, but they're getting paid for that time. They're getting training, they're developing resources together. They have their own community they can share with each other. And that really developed over the last few years more robustly. And it has been a lifesaver for those that don't have the training, but they have skill sets in other areas like the data or the operations. But with that partnership, you have that full mind together, right, to do it the best you can.
We got a few minutes, and I did want to go down to a specific project. And so in 3 or 4 minutes, can you describe a specific project? And we had talked about the community farming, and UC Davis is a big agricultural college and community, and so could you explain the community farm, Reshma?
Hendry, do you want to take the farm side? I can talk to the food insecurity part.
But so we work with a large population of Hmong communities, and originally they were very much agriculturally based cultures. And so one of the things that we recognize is that the medications that we were giving, the treatments that we're giving, they were helping to reduce symptoms, but that sense of thriving, the sense of connection to community, the sense of like feeling grounded in the United States, that was really missing. Because if you can imagine, if you grew up as a farmer and then you get displaced and live in this like multi-dwelling apartment where you can't grow anything, your sense of what life should be is very different from what life is. And that disconnect causes a lot of moral and existential and social distress. So we created a farming group where the elders in the Hmong community who were our patients would teach our young clinicians who were not farmers how to farm. And they would grow produce that they would bring to their family. And they could say to their family members, to the young people, hey, this is how we would grow in the old country. And let me cook this up for you and let you know what it's like to when I was growing up. This enabled them to have a sense of belonging, a sense of community, and sense of rightful belonging in the United States. Unfortunately, as things would have it, the farm was vandalized and swastika signs were painted all over, and the plants were uprooted. And I was actually quite devastated when I learned about this. But my patients came to me and said, "This is our farm. We can't speak English. You all can speak English. Help us to file a police report because this is not right." And that was to me really powerful evidence that they felt like they belonged here.
Yeah.
That we, through this collaboration, had done something right.
Wow. That's a powerful story.
And
Reshma.
I'll just add to that in that I think in that same vein, the work that we're doing around food insecurity and a lot of the changes like in the state of California, where now, food as medicine prescribing is covered for our Medicaid patients as well. There's been a huge movement, and to this issue about that community history, the CBOs that are involved, even our local chef in food and nutrition is a local celebrity. He was in the, he's an amazing chef. Not only that, but actually brings a lot of this and brings bridges between the community into what we do as a hospital. And so that connection for us with food and nutrition is something that I think sometimes we don't always think about as those other groups, and that to build those bridges. In that similar vein.
Well, if I could clap, I would be giving you a standing ovation. And so really thank both of you. Heartfelt stories. You're passionate people, you're smart, you're doing work smart, and it was lots of sensitivity to a lot of factors. And I just think it's inspiring, and it's not your run-of-the-mill community-based healthcare program. And that's why we wanted to bring you on to really dig deep into what you're doing that's so special.